Hey everybody, welcome to Real Mental Health with Dr. Mike Ma. Now we have a very special episode today because we have a very special guest. Here we have Dr. Michael Kanell, double board certified in general adult psychiatry as well as forensic psychiatry. Went to The Ohio State medical school.
That's right.
And did his psychiatry residency training at UCLA where we met, and also his forensic fellowship at UCLA.
Also at UCLA.
Double board certified, ladies and gentlemen. That's pretty fancy.
Well, I guess so.
Yeah. Now, Dr. Kanell, welcome.
It's great to be here. Thank you for having me.
Yeah, and just so everybody knows, I am practicing over in West Los Angeles, and so is Dr. Kanell. We didn't really go too far from our residency program.
No, it's nice here, so you might as well stick around.
Yes. Now, what makes this so exciting? What makes this so exciting for me is that Dr. Kanell, Mikey, as I know him, is an expert in a form of therapy called intensive short-term dynamic psychotherapy. Now, those that follow me on social media and have seen my content over the years have certainly heard me reference ISTDP many times before. And I would say that out of everything that I have learned therapeutically, as far as being a psychotherapist, as a psychiatrist, intensive short-term dynamic psychotherapy is by far the most valuable for me in analyzing patients, reading between the lines, formulating my assessment of them, maybe seeing something that they're not seeing. Now let's dive in. So let's start with telling the audience what exactly is intensive short-term dynamic psychotherapy, and then we'll just flow from there. But let's give them an idea of what exactly is your expertise and specialty.
So, the first thing I want to say is, I was in the same training program as you, and I also found ISTDP to be, it's the most compelling of because in training we get exposed to lots of different therapy modalities. We learn basic supportive therapy. We learn about the CBTs. You get exposure to the ideas of psychodynamic psychotherapy. But ISTDP was it's the most pointed, it's the most clear, I think. And it seemed like it had the most promise.
When I started with my ISTDP training, it was that finally, aha, this is what I have been searching for in my psychiatry residency. This is what I need to learn to look at people and just kind of see what's going on. How do I solve this puzzle? How do I analyze people? What is giving me this special lens of analyzing someone, if you want to call it analysis, we'll get into that, that like the other therapy modalities don't give you.
It gives you such a structure for that. And like that reminds me of when I had that same feeling. I was like, it's like this aha moment. When they start explaining it, when you see the video and you see it in practice, it's like, this is when I was like a teenager and I was before med school and I was like, struggling in my life. And I thought, supposedly there's this thing called therapy out there and it helps people. And you imagine, well, how might it help people? It's going to show me about these parts of myself that I don't know. It's going to, reveal the patterns of how I'm getting in my own way and screwing my life up.
Yeah.
Like that's what it is what you imagine therapy to be. It's the closest that you're going to get to it.
Absolutely.
I really think so.
Now let's break it down, if you could, for the audience, the I, the S. Talk to me about what does it mean and what is so intense about this? Yes.
Yeah, I guess you really should start with the intense part because actually, I thought that therapy would really help you figure out the patterns and stuff in your life when I was young. But as you get to know therapy later on, it's actually much more gentle, because you think about these patterns. If you want someone's life to get better, they have to change. And change is hard.
Yes.
And it will always be painful.
Yes.
Because growth is about being different than what you are. And being different is always the easiest thing. Being the same is always the easiest thing to do. So being different is going to be hard to do. So that's, the stance of ISTDP is that you can be different. So if there's part of the intensity comes from, for example, if you're talking to a patient who's very anxious all the time, or if they have like a history of depression, especially with depression, most people, it happens to them and they have no idea why, and it's really easy to just say, well, I guess I am depressed and this is just how I always was. But ISTDP at the very outset takes the stance that no, there is a cause and you can figure out what it is and you can change, and that can be a lot for people, especially for someone who's depressed at the beginning, because part of being depressed is feeling like you really can't do anything. Depression oftentimes is a really hopeless, helpless kind of position that you find yourself in. And I don't think that people who are depressed are choosing to do that, you know. I think it's something that happens because of a whole complex set of factors in their life that leads to them feeling helpless and hopeless and like, this is just what I am, you know. For some reason, I just always am kind of glum, and, you know, when things are supposed to help me feel better, it just doesn't work, you know. So it's hard in the depressed position to feel like you can do that. But ISTDP is it's about actually changing your life.
And
so it wants to give you the power to do that.
And so several things of what you just said. So first of all, making change is possible. 2,
yes,
ruling out any sort of medical cause. No one is depressed for no reason.
Right.
Now, if you have a genetic predisposition, okay. But when patients come into me and ask me, I always say no one is depressed for no reason.
Yeah, it's not like the flu, you know. It's not like it just happens. And you're like, I don't know. Even the flu has a reason, right? But
Exactly.
it's a reason outside of you.
Yeah, you might not be consciously aware of why.
Yeah.
But no one gets depressed for no reason. Now, one thing I want to bring up a little bit later is bipolar disorder and the occurrences of depressive episodes there, and whether or not that follows the same principle that you just mentioned. We'll get to that a little bit later. So change is possible. No one is depressed for no reason. And importantly, making change and lifting yourself out of repetitive self-defeating patterns and depression is difficult and can be painful. Staying the same is more comfortable now, but if you want to quantify pain over time, if you are depressed, then staying the same, although more comfortable now, is going to lead to long-term symptoms.
There's an automaticness to the comfort, you know, of being in like an anxious position or being in a depressed position. You know, if it's something that a person has been doing habitually, oftentimes since childhood, you know, in reaction to stressors and stuff, then it seems on this superficial level like it's easier. But actually, if you think about the effort, once you break free from the depression, you'll realize that like actually you were doing a lot of work to keep yourself down.
Yes.
You know, that's kind of this untold secret of depression. It's like depression is a lot of work. It's whenever something happens that might lift up some sort of feelings inside you, whether, you know, it's something that triggers a spark of anger or something. For some people, they'll get depressed when something happy happens, you know, because they're not okay with their happy feelings, or if they're not okay with their sad feelings. Like a feeling comes in order to redirect that energy, you have to do something, because the natural thing to do would be to experience the energy and then to have a satisfaction from your feeling. But what the depressed mind will do is it will take that feeling and it will become really in conflict with it. It's not okay that I get happy right now. Someone might see that I would smile and then they're going to try to take my happiness away or something like that. You know,
well, you're saying depression takes a lot of work. Now, so I want you to expand more on what staying depressed takes a lot of work.
Yeah.
And what you just described as far as these uncomfortable feelings or feelings coming up, like, is that happening consciously, unconsciously? So what do you mean by staying depressed takes a lot of work? That's very interesting to me.
Yeah. Okay. And I think a lot of this,
and if you could throw in any sort of examples and make this more clear for me and the audience.
Yeah, because I think the preliminary idea that you have to understand is that there's a lot that's going on inside anyone's mind unconsciously. You know, like just as an example of one of the moments when I really noticed the unconscious was I was in a training for Actually ACT, which is, you know, it's a type of therapy where it's a lot of mindfulness and paying attention to yourself. And they passed around a little box of raisins and everybody slowly ate the raisin.
I remember that one.
You remember that one?
Yeah.
And so then the supervisor there, he was like, okay, now just let the raisin sit in your mouth. I'm letting the raisin sit in my mouth. And he's like, now chew the raisin slowly and chew it. And then after that, there's like the little raisin and like stuck on your teeth. And like, you know, the tongue, like my tongue, I imagine most people's tongues, just automatically starts like scraping the leftover bits of raisin off your teeth with no one watching, you know, with your mouth closed. And the supervisor, he said he brought that to mind. He was like, now notice that's what your tongue is doing. It's cleaning the stuff off the teeth. And I thought, I've been doing this my whole life. Every time I eat anything, you know, and I'm not thinking about it.
Yes.
You know, I'm not like sitting down at the table, you know, having conversation with friends, like eating, you know, my pizza or my pudding or whatever it is, and thinking, and now I'm going to scrape off the stuff from my teeth. I don't think that. It's not conscious. I just do it, you know? So that's a good example of how the unconscious is always at work in your life. You know, it's in this example, it's sort of cleaning off the debris from your teeth to try to keep your mouth clean. So if you grew up in a situation where your parents or like your older siblings or something are like, whenever they see you happy, they can't take it. You know, maybe they're not okay with it. Maybe it's an older sibling who's got like a competition, like a, you know, like a sibling rivalry kind of a complex. And so every time they see you like having won or having succeeded or like being happy and wanting to dance around, they start cutting you down and stuff. Eventually you learn like, oh, okay, this is like a dirty raisin on my teeth. I need to clean that off. And you're not doing this. You're not doing this consciously. It could be deemed
unacceptable.
Exactly. It's like we don't want anyone to see the raisin. So you're not doing this on purpose, right? You just want clean teeth, and it feels unclean because your older sibling is just always like laying into you, right? And so the way that the depression might develop in that situation is the next time that you're about to get a happy feeling, like you feel it in your body unconsciously.
Yes.
And then your body immediately is like, there's raisins on my teeth, you know, metaphorically.
Yes.
And so then it needs to start cleaning the raisins off. And this is how you do the work to be depressed. And here's what the work is. It takes that energy and it starts thinking of what else, literally, is there anything else I can do? And what the depressed mind oftentimes does is it seems rational, but it pushes it to the point of irrationally. It starts trying to figure out reasons why you're not happy, you know?
Fascinating.
So it's like,
being happy, growing up from attachment figures, siblings, was deemed unacceptable. When you were happy growing up, you were cut down.
Right.
Now this is unacceptable. Now as an adult, these happy feelings come up unconsciously, that you've recognized that this is unacceptable and some sort of threat to me.
Exactly.
And
so
to defend or to
stop it from happening.
To stop that from happening because it's unacceptable, you start doing the work of all the reasons that I'm not happy.
Exactly.
Okay.
And these thoughts, they come up automatically, you know, and you're not planning to do this. Like, this is not something, but ISTDP takes the stance that I know you're not planning to do it, but fortunately it is something that if you notice it, like noticing the raise in your teeth, now you have some control over it.
Okay.
You can choose what to do. You
okay.
know? So it brings it to your attention and say, look, you don't need to start analyzing me and like, look, I know I was about to say like, oh, it's just, you know, sure, I won that competition, but I had a lot of help from my friends and, you know, really my teacher, they gave me the outline. And so it's not really my work, you know, like these are all thoughts that will make you feel depressed. Right? Yeah. And for the depressive person, they come up automatically, you know, sometimes they come up so fast that like, you don't even notice the whole thought. You just get a flash of almost like intuition, like the intuition that like, oh, you know, my win wasn't really that big of a win.
Yeah.
You know?
Yeah.
And if you think about doing that 24/7, you know, your whole life, like that's a lot of work.
Absolutely.
Where this came from. You're like, it's, you know, over time, it seems like it's going to be, you know, it seems like it's a lot of work to change it now. And it is. But over time, you're going to be doing so much work just to keep yourself depressed. And you're going to be doing it automatically. You feel like it's out of your control.
But it's still cognitive work. Now, correct me if I'm wrong, but like I think studies show, like fMRI, that the depressed brain is working and consuming more glucose and sugar than the non-depressed brain. So when you say work, the brain is actually literally in overdrive in the depressed patient rather than the non-depressed patient.
If you have felt like we're working with happy feelings right now. If you felt a happy feeling, like a happy feeling it's a big feeling, you know? It's like you see people are happy on movies that really nail it at the end. They always put like a dance party if it's like a happy ending.
Yeah.
Why? Because when you're happy, you want to get up and play and jump around and dance. Like that's all emotions, you know, they have motion in them, right? They're emotions. So the motion of the happy feeling is to play and to jump and to dance, right? The motion of the angry feeling, of course, is to like lash out and to strike and to destroy, right? You know, so like there's always like an emotion, there's always emotion to the feeling.
Yeah.
And like there's so much motion that you want with a happy feeling, like your brain's got to be working on overdrive to cut that down.
Absolutely.
And that's the work.
And I think part of what you do is get people in touch with their feelings.
Yes.
Now, I recall learning like the several components that are part of being in touch with one's feelings. Mm-hmm. Naming what the emotion and feeling is, how it's changing the state of your body. I'm angry, I'm hot, my fists are clenched. Yeah. What is the behavioral impulse associated with the feeling? Who is this feeling directed to? Now, this is one bit of the ISTDP training that I take with my therapy patients, is getting people in touch with their feelings.
Yeah. No, and that's I think the original question we started with was, what is ISTDP?
Yeah.
And if I were really to break it down into like two simple pieces, like here's the two main parts of ISTDP. Mm-hmm. One of those parts is exactly what you're saying. It's helping people to actually experience the things that are going on in their body. Because the depressed person, the very classically depressed people, they don't even, like once they're deep into it, they're not even getting a flash of anger anymore. Like something happens that makes them angry, and then immediately they shut down. You know, they're already like analyzing and rationalizing why the other person's, causing problems and why they're they failed and stuff like that.
Or they skip anger and go straight to anxiety, but we'll get there in a second.
Happens too. Yeah. For people who have who go to anxiety, that's for sure a thing. So the first thing that ISTP really wants people to do is to help them to experience, like actually like have the total experience of your feeling, without having to block it off at all, and to let you could say like the pure feeling flow through you, which can be scary if you haven't done it in a long time. But when you actually experience it, it's intense. So again, intense. It is intense because it's real feeling.
Oh yeah.
But it's not that bad. There's something natural about it. There's something satisfying about having the feeling and not blocking it.
And your feelings and being in touch with your feelings is the compass that guides you towards living a fulfilling life in which you're living, asserting your opinion, your truths, asserting yourself in relationship. Your opinions are the compass that guide you towards a fulfilling life.
Yeah.
So when people ask, you have to be aware that being in touch with your feelings is a requisite for wellness. I mean, would you agree with that?
100%.
Yeah.
Like this is if you can. And I know I have a lot of patients that are depressed and anxious. And if you think about, there's a lot of times, one of the problems that manifests as is they get this real stagnancy in their life. It's like they want things, but they're not sure exactly what they want. And they think they want to go make something happen, but they don't believe that they can make it happen. So, you're depressed in your home when you're not going out and getting things. I can imagine, maybe like a college student who's pretty depressed and doesn't have like a really big social circle and feels lonely. They might come to a psychiatrist or a mental health professional looking for help with loneliness. But the issue is that, they're blocking themselves off, and they're not, like, they have desire to connect with people, right? There's a desire to go out there and have feelings and experiences, and it's getting shut down, And so if they could listen to their feeling would be like, look, it doesn't matter what, you got to go out and do something that's interesting to you, go out and find a place where they're playing games, or, go to a show or something that's interesting to you. Yeah. Depression's the opposite of going out and doing things. It's about shutting down.
Yeah.
So like,
it is about shutting down.
It is, right? And but you're shutting down your feelings, and then you lose that motor, right? You lose the motor, you lose the compass, and then you don't know what you want exactly out of life, So the first thing that I think ISTDP can help people learn how to do is how to actually experience the feelings that they're having in their body. Maybe I should have said that's a second, because in order to do that, you need to do the first thing, which is to stop doing the things that you're doing to block it, So
stop doing the things to block your feelings.
Exactly. Yes. So we call those defenses.
Defenses are something you're doing to block your feelings.
Anything you do to try to avoid or block your feelings from having yourself from having the experience of them. So those are the two things that ISTDP can do. With regard to the blocks, the defenses, the ISTDP is very pointed, and the goal is to be very clear, and it's to be very real time. we mentioned, the past and stuff, and that will all come up, right? But what really matters about in ISTDP is what's happening right now, here in the room between you and me as we're talking,
Okay. So a defense is something that a person is doing consciously or unconsciously.
Either one.
To defend themselves against some sort of feeling, which you would imagine that feeling is threatening, distressful, painful. There's a reason that we are defending against it.
Yeah.
So on ISTDP, this person is sitting right in front of you, and in real time, you are analyzing the way that they are defending themselves against their own feelings.
Right there, because the person comes in with a problem. And if you ask them about the problem, naturally they're going to have feelings about the problem. Either it's an interpersonal thing and the feelings are going to be there. Like when you call up a memory, part of reliving a memory in your mind is real. You might be physically here, but the mind, when it relives the memory, it's accessing all those same neuron pathways, to remember seeing something, the occipital cortex, the eye part of the brain, it lights up, right? If you remember what something looked like, to remember what something felt like, if you remember moving your hand to do something, all these corresponding parts of the brain, they light up, right? Because your brain is experiencing it as real as it can just inside itself. So on that same level, here in the room, if I ask my patient to tell me about this argument that you had with your partner, and if they were feeling anger during that argument, then that anger is going to get stirred up right there in the room. And if anger is forbidden, then also all of these defenses are going to start happening right there in the room.
Okay. So you have a patient sitting in front of you.
Yeah.
You ask them about a conflict they had with their partner.
Yeah.
This patient, let's call him John.
Yeah.
John, growing up, through his life story and his attachment figures or whatever, feeling angry has been deemed unacceptable by his unconscious.
Yeah.
So he's very out of touch with that feeling of anger. He defends against it.
Yeah.
So you are talking to John. Tell me about this conflict you had with your wife in which the anger did come up. And now what do you see? What is an example of a way that John is defending against this anger?
Okay.
So what do you do with John? What do you see in John?
You got to watch John, right? Because it's going to happen quick and it's going to be happening right there. And you got to be listening too. And it's easy in normal conversation, and even in therapy, to miss it because it all happens so fast. It's happening right there. So when you say, John, so what happened, with your wife? Like, what did you get into argument about? And the first thing John says is, well, actually, she was probably right. I probably went too far. Already before he's even told us anything about the argument or his feeling of anger or what was going on, the first thing that he told us right there, that's like a very normal thing to say, right? The first thing that he did was throw himself under the bus.
Okay. How a psychiatrist analyzes a patient in ISTDP. So the first thing he does is throw himself under the bus.
You go line by line, So when you ask someone to talk about something that has strong feelings, and if they have conflict about that feeling, then the defense will happen right then. The first thing that they say might be defensive. Because if you asked him about his anger towards his wife, he could have said, oh, well, she did this and I was just furious because, it felt like she was taking away my power, she was blocking me and I didn't want her to do that. And so I was filled with this rage and I just wanted to, lash out, right? Anger wants you to lash out, right?
Yes. And that's healthy. This person is in touch with his feelings.
That. Exactly.
He's in touch with his anger.
And it's healthy. He's not actually going to lash out at his wife because once he processes the anger, then the next thing he's going to feel is like, gosh, but if I had lashed out, I'd really feel bad. I love my wife so much, I don't want to hurt her. I'm really sad that we had this argument. I want to be close to her.
Yes.
I want to be together. I want us to feel like we're, co-leaders. I want us to work together. They'll have like a real guilty feeling, a healthy guilty feeling where he wants to come back together, and then a positive loving feeling.
Yeah. Now in John,
that's the whole process.
John
didn't do that.
Can't experience anger for whatever reason.
Yeah.
You ask him, how did you feel about your wife during this conflict? He is recalling from memory and he throws himself under the bus. So that is a defense.
That's a defense. Yeah. Because we're here when we're doing therapy to figure out what his problem is, And so we watch him, we see the problem, we're asking about his feelings, and he shows us what his problem is by immediately throwing himself under the bus and not accessing his
let me
feeling.
pause you there. So he throws himself. Now, perhaps we could explain the two types of defenses. There are formal defenses.
Yeah.
And correct me if I'm wrong. Formal defenses and tactical defenses. Formal defenses are when the patient is how the patient defends himself from experiencing his own feelings, and tactical defenses are how he keeps you, the provider, at a emotional distance from him.
Yeah.
Now, part of your job, part of our job is recognizing both the formal defenses, because everybody needs to be in touch with their own feelings to live a fulfilling life.
Yeah.
And also tactical defenses, because people that are putting up guards against the provider from getting in close with them emotionally are more than likely doing that in their own personal relationships. And what else is needed for a good, fulfilling, happy life is having emotionally close, intimate relationships with other people. So correct me if I'm wrong, but you are assessing for both types of defenses here. Is that right?
Yeah, you're watching. So, and when he says something like, it can seem like he's trying to, acknowledge that he did something wrong. So there's something positive about him acknowledging that he has a part in the relationship. But when he doesn't acknowledge what he actually feels towards his wife, that's where you're going to have trouble, because he's going to be in conflict about that now afterward.
Yes.
And but what you were saying, the defense that he was doing right there was a sort of a rationalization. You could call that a formal defense. How did it function? It certainly functioned in between him and me, because I'm looking to see, what is it that he was really feeling? Like, how did he experience this? What was his unique way of experiencing an argument with his wife, And I want to know what's the feeling that he had when it came, when he started getting into a fight with her. And I didn't learn too much about that. All I learned was that when he thinks about getting into an argument with his wife, he just wants to, attack himself and say, he's worthless and he makes bad decisions and he can't control himself or something like that, So I didn't learn about how he interacts with his wife. I didn't learn about what he feels with her. I just learned what he, I just learned what he does to stop all that from.
Yeah, he rationalizes it.
He rationalizes.
So what you learned is how he stops from experiencing the anger. Yeah.
And I didn't learn anything, and I had asked me that. So on that level, that functions as a defense between him and me, right? Because it prevents me from getting to know him.
Yes.
So it certainly functions as a defense that prevents emotional closeness with me. He didn't show me his emotions, right? He showed me a rational thought. A tactical defense we oftentimes think of as things that they do in the moment to try to avoid quickly. So you could classify that as a tactical defense if you wanted, because it did tactically, I think.
Tactfully?
Yeah, well, certainly tactful also, because that's common.
Let me pause you there, and perhaps for the YouTube audience or whoever watching, is there some utility in discussing tactical defenses so perhaps people can pick up on when others are utilizing tactical defenses to keep them at a distance? So if you notice these things, perhaps someone's trying to keep you at a distance.
Yeah.
Tactical defenses. Can you give us more on things you can spot where someone's trying to keep you away from them?
I don't think there's any harm in having that knowledge. I will say, though, that if you ever to point out a defense to a person, if you point it out to someone, it always comes off as aggressive. That's another part of the intensive short-term. Because our job as therapists is, when we're doing ISTDP, is to point it out, is to, then I would tell John, hey, John, so I asked you to tell me how you felt with your wife, and you told me, you gave me some rational thought about how you're not worthwhile. You made a dumb decision or something. You didn't tell me. Do you notice that you did that? Oh yeah, I guess I did that. Do you notice that you didn't tell me anything about how you felt towards your wife? Oh, well, I thought you needed it. Well, I know you thought that, but we're trying to get a sense of how you deal with things, So do you notice that you gave me a thought instead of a feeling, right? So that's very aggressive. It's pointed and it keeps him on track. Naturally, people might have some sort of a reluctance to hear that, So the audience, it's good to know about what people are doing. It can give you more awareness in the world, but also it's good to know that, these are not things that I would ever do in like normal life,
of course,
with my own partner or with family or friends, because it comes off as aggressive.
Okay, well,
so let's talk about some tactical defenses. Good question, right?
Yeah, and I'd also be fascinated to know how you draw that line in your marriage.
Yeah.
As far as when, overanalyzing your wife. I mean, I might be guilty of that in my own marriage.
Yeah.
But yeah, let's talk about tactical defenses, and then let's bring in after that an interesting discussion of being a psychiatrist, being married, recognize when things are happening, and of course, dealing with your own bias. I'd be interested to hear what you have to say about that. But tactical defenses
that's very
first.
important, for my own personal. Yeah. So, but tactical defenses are things that people do to try to like blunt the feelings like really quickly and in the immediate vicinity,
And a tactical defense has to do with another person, right?
Yeah, it's a tactical. Well, I guess you could technically do it with yourself, but when you're paying attention to them, you're paying attention in a dyad, right? Mm-hmm. Triad. So if you ask someone, how do you feel, and then like if you ask me how do I feel about this guy that cut me off, and then I go like this, traffic's just always bad in LA, and like I'm not looking at you. Right? The first and most classical of all the tactical offenses is to break eye contact when you're presenting, because you asked me about this guy that cut me off on the drive in today, and like I get a surge of rage, right? Because you get a surge of rage when someone cuts you off. You're not getting what you wanted. You wanted to go smoothly, and you had to react to his plan, So to get a surge of rage, if I'm not comfortable with that rage and I don't want you to see that rage, when you make eye contact, there's always the risk that the other person could see and experience and kind of like mirror the feeling that's inside you.
Yes.
In that exact same moment. And that's super dangerous if you have conflict about your happy feeling, angry feeling, sad feeling. So you break eye contact.
And this is a tactical defense against emotional closeness.
It is.
If you maintain eye contact with that person, they now have more of a emotional connection to you.
Yeah.
And tactical defenses are to keep people at an emotional distance.
Yeah.
That is what tactical defenses are employed for.
With your eyes.
So that's one example.
That's one example. But the eye contact is interesting because I learned this recently, but a baby, when a baby's born, they can't see very well, right? Mm-hmm. So the first thing that they can see, they can focus about like a foot, 12 to 18 inches away from them. Mm-hmm. And so the first thing that the baby's ever going to focus on are the eyes of the caregiver, the eyes of the parent, that you're holding the baby in your arms.
Fascinating.
They look in your eyes, and that's what they're making eye contact. So the first thing I said this earlier, the child's job is to match, right? It's to bond. It's to be with the caregiver. And that's evident from the first moments of life, when the baby is first able to start looking at things. The first thing they're going to be able to resolve, the first image they're going to connect with is going to be the eyes of the caregiver.
Wow.
So eye contact is supremely important. And that's why it's one of the first things to break if you don't want someone to see you.
Wow, that baby's only job is to match and connect. Its only job is to not be abandoned by the caretaker, so it doesn't die.
Yeah, and it feels that connection is secure when it can look in the parent's eyes and the parent can look back and they can be at ease with each other.
A little aside. So, depression.
Yeah.
Things exist in life. Human behavior exists, and things exist because at some point they have served some sort of evolutionary advantage.
Yeah.
So getting the state of major depression, here we are, hundreds of however long humans have been around, depression, the state of depression has propagated with us.
Yeah.
Does being depressed serve any sort of evolutionary advantage? Because do we agree that most things happening right now have served some advantage to be with us today, even if they might come of more of a cost than a benefit? But does being depressed serve any advantage?
You're speaking to a principle which I think is, and this is more common in like psychotherapies nowadays. Maybe back in the 40s, I don't know. I always imagine that the older psychotherapists were more like rough about this sort of thing. But you're speaking to like the part of these self-destructive things that we do.
Yeah.
And you're saying, well, why are we doing them? Was there any reason for it? And the answer, I think, I can't speak to evolution because that's not what I know. But what I do know is I've met a lot of people and I've heard a lot of their stories about where the depression is developing, and I think that the depression, or whether it's anxiety, some people, one of their set of defenses is they get really busy. That's obviously very adaptive in like modern American society.
Yeah,
these people tend to do well, right?
I call that the manic defense.
Yeah, that's like the manic defense. Good one. Yeah, the busy defense, the productivity defense, But depression, it clearly, I think it always develops. Maybe, for any person, there could be like a predisposition. Some people, maybe there's a genetic predisposition to be more mellow, right? But if in the environment where you grow up, there's always an adaptive reason, and if you ask enough questions, saying, well, what was it like? What was happening? What's going on is maybe the person had a predisposition to sort of shut down when things go hard, but then things got really hard really quickly in their childhood, and so they went to their predisposition to shut down, and it worked in the sense that like the feelings went away and maybe the persecutor sort of faded away.
Yeah.
Or maybe like the tension went away. If you had a parent that was yelling at you because you didn't do your chores or something and you shut down and you become very penitent and you say, oh, I'm such a bad person, like I really should. Or you think to yourself, if I had just done the chores, then none of this would have happened. This is my responsibility, rather than the parent could be parenting better. If you don't think that, right? So if you have thoughts like that and then it works, right? The parent gets off your case, you go back, you go to your room and you just sit there, depressed for a while. Like that's successful in the sense that now you don't have to deal with the conflict inside. The parent left, right? Now there's not so much stress.
Yeah. What you're saying now, it brings an idea. So it's like what leads to a depression? It's maladaptive coping mechanisms. You would think that if what leads to depression are defenses that are maladaptive as an adult, perhaps, and these maladaptive adult defenses were once adaptive as a child when you're dealing with your attachment figures.
Yeah.
So perhaps there's a greater evolutionary advantage making it through childhood with these adaptive defenses at the time, that you make it through childhood, but then the price is that these defenses as an adult then lead to a depression. So perhaps the evolutionary payoff is that the way you learn to defend yourself as a child gets you through childhood when you're no longer dependent on the attachment figures.
Yeah.
But then the ultimate cost comes as an adult.
Yeah.
But it gets you to the age in which you can reproduce.
Can have your old children.
And
then you'll
I don't know, I'm
pass it
just
on
coming
again.
up with this now.
No, there's another step though after that, because I'm following your thought. The next step would be that, oftentimes we don't just come up with these ideas all by ourselves. There may be genetic components, right? But also there's going to be a learned behavioral component. And oftentimes the depressed child, if you look to their parent, you'll find at least one parent who also has some history of depression, right?
Yeah.
And so there could be a sense of modeling that they're picking up on from them, but also when I think of a child, I think the most important, like the core driver of a child, because human children are so unable to care for themselves, right? Notoriously in the animal kingdom, we're not born walking, right? We're born completely dependent on the caregiver.
Yeah.
And so the one thing that we do intuitively and instinctively that is the most important thing, the spider spins its web, what do? We try to link up with our caregiver. Yeah. Right. We have as a baby, as an infant, as a small child, as a middle child, like you have to link up with your parent. If you can't get in good connection with your caregiver, if you don't feel like there's a strong bond there, then your life is literally at risk. Literally. And so if your parent is modeling like, look, when things get bad, when you have feelings that come up and it could cause conflict, here's what you do. You shut down, the kid will probably even hear the parents sometimes say, gosh, if I would have just, I'm so stupid. I shouldn't have done this. Or if it's someone who has like an eating problem, I shouldn't have eaten too much. I'm so lazy, yada, yada, yada. Whatever the parent says, right? You're modeling that for the kid and the kid's picking it up. The kid has to unite with you, has bond with you, has to model themselves off of you to try to be with you, to try to feel safe. Absolutely. Right? And so then that's another way that it might pass on.
And that's a fundamental principle of psychodynamic therapy is it so much depends on you as an infant and child, your attachment figures, what you as a child felt was deemed unacceptable by your attachment figures. Because if you acted that way or felt that way and it was unacceptable by your attachment figures, that is now a threat to your life.
A threat
because
to
if
your
they
literal
abandon
life.
you,
Yeah.
you're dead.
You're dead.
What are some other tactical defenses?
So other tactical defenses. Other tactical.
I'll give you an example of one
like,
I see often is galloping speech.
Yeah.
It's the person who you cannot get a word in and keeps talking and talking to not allow you a moment to ask a question
good one.
or to challenge. We all know that person. Galloping speech is a common tactical defense I see when people don't want you to get in and ask any questions or challenge or give any sort of opinion. Galloping speech is one thing that I see.
Galloping speech is one thing that you're going to see. A smart one that people use is changing the subject.
Yeah.
You know,
Diversification.
Sometimes it's connected with.
We see that
speech.
politically a lot.
Yeah. Ask
Kamala
a question. Don't answer the question. Just present it. I mean, it's a standard move. I think I don't know much about like political speech or anything, but my understanding is that most people, when they're trained to do interviews, they're trained to listen to a question and then to answer the question that they want to answer, rather than to answer the question that was asked, right? And so people do that intuitively and instinctively, you know, like you ask someone about like this example with John, you ask him, how did he feel towards his wife when the fight? And he tells you about himself, you know, that's not on topic, right? If you ask me how I felt towards the guy who cut me off, then I say, if I don't talk about how I felt towards him, maybe I talk about traffic in LA you know, it's always a mess. It's always a mess. You know, it's dismissive, right? Dismissing is another tactical defense, right? To just say, oh, it didn't matter. Actually, I had a patient the other day. That's what happened. You know, they were in an argument with their significant other, and like as they're telling me about the argument, they say things that the other person said that bother them, and then they immediately follow it up with like, I don't give an F about that. You know, and it's like, no one, I mean, you know, you immediately tell me you don't care about it, but I mean, it's obviously we're here, we're talking about it. You've got some feelings. You got galloping speech. Your foot's tapping. It's a sign of anxiety. You know, clearly you're experiencing something.
Absolutely. You know? Okay, so we have some examples of tactical defenses. So intensive short-term dynamic psychotherapy. So part of what makes it intense is recognizing how people are defending themselves against uncomfortable feelings. You recognize how they defend themselves from you getting close to them, and you push and you challenge, which if you push and challenge someone's defensive points, of course, that is aggressive.
Yeah. You're trying to expose them.
You're trying to expose them because you want them to get in touch with their own feelings, and you want them to recognize how they're keeping people away from them emotionally. Now, what I want to get to next, so we've discussed the two defenses. Now, what I want to get to next is what a lot of the audience wants to hear about is anxiety.
Yeah.
What is anxiety? How do you assess anxiety? How does anxiety manifest, whether it's cognitively, somatically? And perhaps what are some tools you utilize with your patients so they can get in touch with what's making them feel anxious? Hey, doc, I'm feeling so anxious. I have no idea why. And perhaps how they can get more insight into themselves to feel less anxious. So let's dive into anxiety from an ISTDP or from your perspective.
Yeah. Hopefully we can get through all that. That sounds...
We have a lot to talk about. We have plenty of time. Yeah.
So I'm going to try to keep it all in mind. But what I want to say, you bring up anxiety. We've talked about feelings. We've talked about defenses. And now you bring up anxiety. We've actually just completed one of the core concepts of ISTDP, which is the triangle of conflict.
The triangle of conflict.
Yeah, this was first outlined by a psychoanalyst named David Mallon, who was from the UK. And he worked with the guy who sort of organized ISTDP named Avenue. But he came with this idea of two triangles that you can use to guide your work in therapy. And one of those triangles is called the triangle of conflict. The triangle of conflict has 3 corners. And these are different positions that the person might be taking in actual real time in the room with you, you know? So at the bottom of the triangle, this is the core, the center of the person. This is the the natural impulse that a person feels, you know? So if they feel they have like a happy feeling and the impulse is to like, you know, smile and play and be joyful, you know, then that's
the natural state
impulse.
core impulse is one side of this triangle.
Yep. So you got the core impulse at the bottom, or the feeling. And then on one corner, you've got the defense. That's the thing that the person does to avoid having that feeling, to avoid experiencing the impulse, to try to redirect it, right? So that's the defense. And then on the other corner of the triangle is anxiety. Anxiety is the core part of the triangle. It's called the triangle of conflict because this is the set of things that a patient might do if a conflicting feeling comes up. You know, we've talked about having conflict over anger, and that makes sense because there can be bad outcomes if someone acts out their anger, right? But there's also conflict over sad feelings and happy feelings, depending on how the patient, you know, what their upbringing was like. So when a feeling comes up that you have conflict with, then what do? You try to make that feeling go away by doing something defensive, right? But why do you do that? Well, because when you have the conflict, the experience of the conflict is distressing, right? It is distressing. And distress is felt in the body. It's physically it's in here, you know, it's in here somewhere. And that we call that distress anxiety in ISTDP. We're not talking about anxiety like classical, like, you know, generalized anxiety disorder, check these boxes and now this is what anxiety is. We're talking about the actual visceral experience of distress that you have.
And what does it feel like? Like, what does anxiety feel like in your body? How can it manifest physically? I know it's different for different people, but how does it feel like and how can it manifest?
So that's an important thing to note, is that it's different for different people.
And also I know that you recognize that, sorry to interrupt, is that you do an anxiety assessment.
Absolutely.
Because you can tell how severe someone's anxiety is based on the physical symptoms that arise from that anxiety. So perhaps we can go through that, an anxiety assessment, how it's manifesting physically, and what that tells you as a provider as to how severe this anxiety is.
This is super important in ISTDP because it's intense. You really need to be monitoring with the patient. Hopefully they can monitor with you, but it's on you to kind of lead the way. You need to be monitoring how much anxiety they're getting because you don't want them to go over threshold.
Of course.
But also you don't want them to have no anxiety, because if there's no anxiety, then there's no change, right? So anxiety is experienced. The way you teach about anxiety in ISTDP is you think about it in 3 different levels, okay? The lowest level, which is the level where you can actually work and make change, and it's distressing enough that you want to fix something, but not so distressing that you're overwhelmed. This is anxiety that's felt in the muscles of the body. Like when you think about muscles, just the normal thing that an average person in society would think of muscles, the muscles in the hands, the muscles in the legs, the muscles in the chest. You know, if a person takes a big sigh, that's movement.
I'm tense in my shoulders. I'm tense in my neck.
You're holding it up in there. You can see their shoulders are high.
So this is level 1 anxiety.
This is level 1.
This is where you want people to be during therapy, because being a little bit anxious during therapy is helpful for the process of making change. And this is anxiety felt in your muscles. Is it the muscles that we're familiar with? The muscles like you just described.
Any muscle that you can voluntarily move in your body.
Your skeletal muscles.
Your skeletal muscles. Any of those muscles, that's anxiety. That's okay to work with.
Okay to work with.
That's a good level of anxiety for therapeutic work.
Yes.
You know, and so the next level of anxiety is anxiety that's felt kind of in you can think of it as in the organs or in the muscles that you don't have control over if you look at it from a more medical standpoint.
Your autonomic nervous system.
Yeah, you're thinking like the muscle, they're thinking the tightness in
Smooth
your blood
muscles,
pressure.
yes.
It could be like you get higher blood pressure. You could get like cramping in your stomach, maybe some diarrhea or some nausea. You could have that. That's the way that could happen. Anxiety that's in those muscles, if your therapist is asking you, how did you feel towards your partner, when they yelled at you, and then, you don't feel any of the heat of anger, and instead you just feel nauseous. Well, that's a lot of anxiety, and that's too much. You don't want to work with that, because that's saying that the anxiety is the problem then, and you want to try to lower the anxiety before you can get back to dealing with the feelings.
Yeah. So that's too much. Now, just a quick 2 sentences, like irritable bowel syndrome, IBS.
Yeah.
A lot of the times that's secondary to anxiety.
Yeah.
Now, can you connect it with what you just said?
There are a number of ISTDP providers who are doing research on this, I believe, right now.
As far as irritable bowel syndrome,
Yeah.
I hear some ISTDP providers even saying that ulcerative colitis can be secondary to an anxiety manifestation in your smooth muscles, which I
Yeah.
believe is what you are describing. But, well, what do you think about that?
I've heard people say that too. My personal thoughts, I mean, for irritable bowel syndrome, classically it's a functional disorder, which means that you don't see anything on any of the scans or any of the tests. Like there's nothing that they can see that's physically causing it. So I tend to think that that is most likely entirely caused by, anxiety that's gone over threshold.
I do
People
too.
who are not able to really, like, for whatever, it's not their fault, right? But whatever they get over threshold when they get feelings, And I actually had to pay when I was in training, one of my first patients that I was working with was a person who had very serious like IBS, and like when he would take tests and things, like it was really, he was having a trouble in school because he'd go in for like a calculus test or something. And then he would just get a rush of diarrhea and he'd have to like bail from the calculus test and run to the bathroom if he didn't want to have an accident because it was just so intense, And he was clearly getting anxious. It was about like performance, about competition, and it's about, he had some conflict over, success and failure, like that sort of thing. He needed to be rigid and perfect. And so this was a way that his body was fighting back. I mean, like, look, you can't be perfect,
I have seen the same. I have seen absolutely cases of patients that get sent to me from their gastrointestinal doctor because they have IBS. They think it's from a psychological cause. I do an anxiety assessment. I get to know the patient. We treat the root cause of their anxiety and their IBS improves. Now, so you've discussed that first level of anxiety where it discharges into your skeletal muscles.
Yeah.
That's good. We want to work with it. Fine.
Yeah.
We've talked about the more severe second step where your anxiety is being discharged into your smooth muscles. Too much. Not something we want to work with. We'll work on reducing that anxiety.
Yeah. And then
now
the third level, this is going to sound familiar to a lot of people. There's a lot of talk I hear about like dissociation and things like that. That's the third level. This is anxiety that gets into the mind. Like you're so anxious that you can't discharge it just by shaking it out in your muscles. You can't just tap your foot and then you're calm. You can't pace and then you're calm. You're so anxious that you can't even like have a bowel movement and then that's going to relax you. It's not just a headache. Now it's your entire mind just goes, there's a number of things. Maybe you'll get perceptual changes. You'll get tunnel vision. Maybe like you just won't be able to focus. You'll be looking at something. You'll feel like things get really far away, even though they're not really. There's no distance change. You get like a floaty feeling. It's harder for you to track a conversation. Some people when they go, if they have like performance issues in school, let's say that they do just fine on homework where they can go home and, open book, be careful, think about it, come up with good answers, but then they have to go perform and go do the test in real time and it's much harder for them. Yeah. This is a high level of anxiety.
Performance anxiety.
Yeah.
And this is what you also have to rule out. Quick note, ADHD patients that come to me that are anxious, you have to rule out that the anxiety is not cognitively impacting the person to the point of causing attention and concentration issues that mimics ADHD. So first level, second level, the third level is perceptual changes, dissociative. I'll tell patients, some people can be so anxious that they will get lost walking from their bedroom to their bathroom.
Absolutely.
Their short-term working memory.
Yeah.
This is severe. What do you do with this? When you see this, what does this tell you?
Well, no, originally when ISTDP was developed, actually a lot of providers would say if the patient is regularly going into, cognitive perceptual disruption is the term that we use for it. If the patient's regularly having that high of an anxiety and it's just overwhelming them, originally they would say, well, I don't know if we can really do this therapy, because we're going to be pressing for feelings and then you're going to spike up and then that's not going to work. But in more recent years, there's a fellow, a doctor named Alan Abbas, who's up in Canada, and he's been doing really great research and really great work. He's worked with a lot of people who have dissociative disorders and who are, you can think of it like that. It's a very fragile tightrope they walk, where a feeling comes up and then they immediately go over threshold into just like overwhelming cognitive anxiety. And so he's developing a way to really kind of be sort of very gently, like kind of help bring down the anxiety to a more tolerable level, and then introduce the feeling with, like, approach the feeling together with the patient just gently, and then watching to see it go over threshold again.
What does over threshold mean? Will you explain to the audience? What does it mean when anxiety is over threshold the way you're using it?
So the threshold is just after that first level of anxiety. From level 1 to level 2, that's the threshold.
The threshold for what?
The threshold for now, you don't want to be pushing for more feelings.
Yes. So the threshold that in therapy, as a provider, if you see the patient's anxiety rising past this threshold, you are no longer pushing in and challenging. At that point, you're working with the patient to regulate their anxiety, to bring it back down to stage 1, because that is where the productive work can happen. If I have a patient sitting in front of me and I'm pushing them and we're bringing up feelings that they have a lot of conflict about, and they start telling me, hey doc, I'm getting like nauseated, or my ears are ringing. I'm now switching gears. I'm not pushing, I'm not challenging, I'm not inquiring. I'm done with the incisive questions there. We're now regulating their anxiety to bring them back to stage 1 where we can do productive work. A question for you: when you have patients in session that go above threshold, how do you regulate their anxiety? Now, everybody watching these, perhaps you could learn how to regulate your own anxiety when you're feeling very anxious. Maybe that is a lesson here. How do you regulate the anxiety of a patient real time in clinic with you and bring them down to level 1? How do you do that?
Well, so the first step is to slow down and take a pause, because whatever it is that's happening that's bringing up the feeling is something that you're actively doing. So you want to stop doing that.
So take a pause in the work.
Immediately take a pause in the work, right? Then the next thing you want to do is you want to start actually paying attention to your body, because you say there's something very, like we call it grounding, there's something very settling about being able to notice what is actually happening in your body.
So you get the patient in tune with their body.
Yes. And you can do that through it. I mean, one of the simple things to do is you can just do a simple body scan. You'd be like, I think I'm feeling a lot of anxiety. I think I'm overwhelmed. Like, where am I feeling the anxiety? And just start from the top and go to the bottom. Start from the bottom, go to the top, do it in an organized fashion. And then the order will provide you a scaffolding that you can lean on while you're, overwhelmed with your anxiety. You can start with your feet. Say, do my feet feel, am I squeezing my feet? Are my feet relaxed? Are they tight? Is there a buzzing feeling in my feet?
How does this help them feel less anxious? Scanning their body like this.
Well, it's because it's them getting in tune and paying attention to them. The anxiety is a signal that you're in distress. And when you're in distress, you want someone to pay attention to you and care about you. And at the very base, you can always pay attention and take care of yourself. And this is you doing that. It's offering yourself a little bit of an olive branch, a bit of support, giving yourself a little bit of care.
And what I have found is that when we're feeling in that really heightened anxious state, people get very fearful, like there's something going on with them that's dangerous. So when you bring them back to reality, this is what's happening. You're feeling very anxious. The sensations as we scan through your body are manifestations of anxiety. You're not having a stroke. You're not having a heart attack. Regulating breathing. I mean, that's almost step 1 for me, is like the breathing regulation. So here we're getting in touch with their body, the body scan, the breathing. What else do you do to kind of bring them down from their anxiety?
So there's 3 classical things that they usually think about in ISTDP. The deep breathing is one of them. It's easy to start with, right? Anyone can learn how to do deep breathing. There's a practice to it, right? It's about learning to relax your abdomen and relax your diaphragm to have it really pull deep, There's the body scan, right? Which is where you pay attention to your body and you really try to notice what's happening there and actually care about what's going on inside your body. And then to really also experience it, because the more you pay attention to it, the less overwhelming it's going to seem. If you've got just tightness everywhere and nausea and cramping and your mind's scattered and you're not paying attention to it, it feels incredibly overwhelming. But when you notice it, you can catalog it. Now it's more understandable. It's not overwhelming anymore. It's manageable.
Absolutely.
Right.
Don't avoid the fear response.
Right. Understand it.
Understand it.
Yeah. So that's the second one. And then the third thing is, you can always change the subject, go back to something that was comforting and calm, So, people, if you're by yourself and you're having like an anxiety attack, you can do things that what they'll oftentimes recommend is having a list of things that usually are relaxing for you. If there's music that you like to listen to, or if you like journaling, changing the subject is because it's the subject, it's your conflict, it's your conflictual reaction to the feelings that come up in the subject that are causing you, that you're having anxiety about. So if you change the subject, then there's nothing to have anxiety about and it should fade.
Okay. So we've talked about assessing anxiety in the patient when they're in your office. Right. We've talked about the 3 levels of anxiety and where you want to be to get good work done. We've talked about when someone's anxiety gets too severe in session, how to regulate them and bring them back. Now, what do you think we should discuss next? What do you think is...
I had something on my mind that I wanted to share that I was thinking about coming in. I had a roommate once earlier on when I moved to Los Angeles who didn't really believe in the unconscious. And I was trying to think, I know there's people out there that don't really understand that the unconscious is something that exists.
What is the unconscious? Explain to the audience. What is that?
So the unconscious is the part of you that is managing your life without you noticing it. It's not anything mysterious, but it's always active doing things. And I had this thought that I was like, that what ISTDP allows you to do is it allows you to find these parts of your life that's being managed that are outside of your awareness and in a sense outside of your control, and it brings them into your control. And I had the thought that like, it's kind of like sleep. You might not realize this, but babies don't actually really know how to fall asleep when they're born. If you watch movies, you'll see that the mother is like, the mother, the caretaker is always like holding the baby and shushing it and singing a song and rocking it to sleep. And that's because the baby doesn't know how to do sleep. Like, how do you do sleep? It's about relaxing your body. It's about relaxing your mind. It's about decreasing stimulus and then letting your body, go to sleep all by itself, But the baby doesn't know how to do that. And so the mother relaxes the baby's body for them by shushing them and rocking them. And people have a lot of trouble going to sleep when they become adults because it's like they forget what they learned, when they were a baby. They forget that they learned how to go to sleep. And this experience of going to sleep is a bodily experience. Yeah. It's something that you experience in the body. And it's tough to really describe in words exactly what you do. It's like, how do you move your hand? You ask someone, how do you move your hand? You can't tell me. You couldn't describe to me like, oh, I think in my brain that I'm going to move my hand and then you just move your hand, right? You just do it. It's something that you do with the body. Yeah. And that's the way sleep is too, which is why it's hard to teach how to do, right? So we teach all these other things around it and help people learn how to relax themselves and then allow sleep to come. So ISTDP is similar to this, where it's very, in contrast to some other therapies, it's very bodily focused. It's about the reality of living in this body that you have, the one that's here, the one that exists in the world. And the feelings that you have, the happy feeling that makes you want to jump around and play, or the sad feeling that makes you want to cry and reach out for help, or the angry feeling that makes you want to assert yourself and push back, stop things from happening. These are actual physical things that are done by the organs of your body.
Physical states of the body. They're not just thoughts.
Yeah, they're not just thoughts. Thoughts are part of it, right? Because the brain is part of the body, but it's just a part. There's the whole rest of the body. And so in the same way that a person needs to learn how to go to sleep, or like a mother teaches a child how to sleep, or a child learns how to move their hand, or if, for example, if you don't know how to wiggle your ears, you've got muscles there, you can do it. You have to learn how to access those muscles if you want to learn how to wiggle your ears. Like, these are bodily experiences that you have to learn how to do. And learning how to experience anxiety, if you've experienced anxiety, experience anger or happiness or sadness, if you've been blocking it for all your life, that's something that you can do in ISTDP, is learn how to reconnect with this whole part of yourself that has been avoided, ignored, turned into depressive thoughts, turned into anxious ruminations, turned into like self-doubt and worrying, turned into fights with other people when they push your buttons, Like ISTDP is about reconnecting with the you that exists, the physical you, all of you. Absolutely. I just thought that was like a really cool idea.
Love it.
Yeah.
Now, speaking of which, a question I get all of the time, how do I stop ruminating?
Yeah.
What is your answer to that question? Doc, how do I stop ruminating? What is ruminating and how do I stop?
So we call ruminating, that's actually one of the classic defenses that we deal with in ISTDP. If you find yourself ruminating, you could think about the content of your ruminations, but that's just going to be more ruminations, and maybe they're reasonable, maybe they're helpful,
And let me just pause you for a second. What does ruminate mean? Ruminate is like it comes from the word that is like a cow literally chewing its cud over and over. So again, to ruminate is when you are chewing and going over an idea over and over again excessively to the point where it is not serving you. Am I right in that description?
Absolutely. So if I had a patient in my office and they said that was their chief complaint, they're like, Doc, I'm ruminating all day long. I want to make things happen, but nothing's happening. And I get so stressed about what might happen. Then I'd be like, okay, so you try to support their distress there, because obviously they're in distress. And then the next question is, so when is the last time that this actually happened?
Yes.
Like, are you ruminating right now here in the room?
Give me a specific example of the last time this happened.
Right.
Yes.
So that's another, in the same way that ISTP is great because it's so clearly focused on your real body that's really happening right here. It's also focused on real things that are happening in your real life right now. So if you're having rumination problems, we're not just going to talk about rumination generally. We could do that, but honestly, that's just more ruminating, right?
Yeah.
So instead, we're going to say, when's the last time you were ruminating? Bring it up. Let's get into the depth about what actually happened that day.
Exactly. And so you're classifying rumination as a defense.
Yeah.
And what I have found is what one person is defending against is not always connected or related to the topic that they are ruminating about. Sometimes people will ruminate about one thing to actually defend themselves and distract themselves from thinking about the actual feeling that they are conflicted about. So
yeah, that's actually, they're doing kind of the rumination, the same thing that we do to try to like lower people's anxiety. They're changing the subject in a sense, right?
Fascinating.
They shifted off of the thing.
So sometimes someone is ruminating about one thing to change the subject.
So they're not,
from the more painful, distressful, conflicted feeling.
Yeah.
No, and again, whenever patients ask me, how do I stop ruminating? It's always so difficult because it's such an individualized question based on the person. But do you have any sort of advice for people, Doc? How do I reduce my ruminating?
Yeah, well, if I were to say something generally, I would say the first thing is to understand that the rumination is not necessarily about the thing that you're ruminating about. And then the second thing is to ask, what else is going on in my life right now that I'm not dealing with? Because I mean, 9, maybe even 10 times out of 10, if you look at what's going on that day when you're ruminating and think about the pressures that you have and the things that you desire, your real desire, you'll find something that's really bothering you, something that you actually want to work out. So I think that's, that's what I would do. And that's what I would do in the room with the patient. If they asked me that, I'd say, let's go back to this day. It was on Thursday. That's, we're meeting on Friday. It was yesterday. What was happening in your life yesterday? Did you go to school? Did you go to your job? Was there a task that you got at your job? Did something happen? Maybe you were at your job and you had like a deal that you were going to make and then the deal fell through. You spent the rest of the day like ruminating on like why the deal fell through. That's at least related, but think about, what is it that's happening right now with your desire for mastery, and your desire for success, and what sorts of conflict do you have over that, and what sorts of feelings come up? maybe if the deal fell through, maybe there was a person, maybe you have like, a colleague, who failed to show up when they needed to, or maybe it was the person on the other end of the deal, who like reneged on something that they had agreed they were going to do. And maybe you've got some feelings towards them. I would ask that, and then we would see what comes up. If I ask, this person, what did you feel towards this guy when they canceled the deal? And then they start ruminating, they start explaining all the aspects of the deal and how, well, maybe it wasn't a good idea for them anyway, or how maybe the guy's just he's just a two-faced, just a two-faced liar or something. Like, none of that is his feeling, right? Yeah. That's all just description. Yeah. It's just more rumination. Yeah. If I ask him, how does he feel towards the guy? And he says, well, gosh, I'm pissed at him. I'm furious. I'm so mad. I'm like, okay, so now are you experiencing that? How does he say that he's mad? Is he like with a flat face, like, I'm really angry at him? Because that's, where's the anger? Yeah. I want to try to, then I would say, well, clearly he's not showing me the anger, and he's not showing himself the anger. And so there's obviously conflict about it. Yeah. And you say, do you want to take a look at this and try to figure out what's really happening inside you?
So perhaps the rumination there is a defense against the actual feeling that he has a difficult time experiencing.
Like, maybe it's not
defended
okay.
against.
Like, maybe he wants to make a deal with this guy again in the future, so he doesn't want to get too mad at him, because then he might come through later.
There's the conflict.
You got some conflict about this anger. You know? So the paradoxical thing is, if he could actually experience the anger, like experience falling asleep, like whatever, like the total actual experience in his body, then he would be free, because he could satisfy the anger just by experiencing it. And then he would be free to have other feelings towards this guy, Then the ruminations might be useful. Then he could have some empathy for the guy and be like, he was trying to do his best, He's got other pressures than I do. Now I can approach him as a human, human with him, not as a guy who's like angry at him because, he filched on his end of the deal.
What do you think about the saying is, when someone is ruminating, it's because they can't believe the lie they're trying to tell themselves?
Yeah, I mean, it could be if the lie is that, like, they're not angry at this guy, or that, something like that would make sense. There's actually a really good book that was written by an excellent ISTDP therapist whose name is John Fredrickson. And the book is literally called The Lies We Tell Ourselves. It's very short. It's a tiny little book. You can read it in like
I've read that book. Your wife recommended it to me.
Yeah, it's a good one. No, it's great. If anyone ever asks me about something, if they want to know about what therapy can do for them, I say this is the book to start with. Yeah. It's so clear, and it's about trying to see these parts of yourselves that you're missing.
Yeah, and the lies that we tell ourselves, again, these are defenses. It's lies that we tell ourselves to avoid accepting the truth of which is painful, distressful, requires change, may hurt other people. People are lying themselves all the time. Yeah. And that goes into my next question for you. Can you describe to the audience, what is the ego? What is the function of the ego? What does it mean? We don't have to get too Freudian and talk about the id and the superego. If you want to just throw in a little bit about those, you can. Sure. But what is the ego?
So the ego is the part of the self that manages the interface between all of your internal desires and all of your societal expectations and all of your like community and family and friends' expectations of you, and then the rules of the outside world that you have to follow, and then also the balance of like natural reality, the physical rules that you have to manage, and then also the things that you want to have accomplished in your hopes and your dreams. So the ego is this part of you that tries to figure out how to make everybody happy. And it can be overwhelming for the ego if it doesn't have good practice. It doesn't have a lot of flexibility in doing that. If you have a happy feeling or like a sexual feeling or an angry feeling and you want to satisfy that urge, that's something inside of you. But then, there's all these social rules around what are the okay times and places when you can satisfy a happy or a sexual or an angry feeling, like when is this sanctioned and when is this okay? And then there's also the physical reality, there literally could be things like the weather or, the location, the time of day. The ego is the part of you that's aware and alive and is trying to get all of this taken care of. Yeah. If you're hungry or if you're tired, You know, the ego is that's their job.
Yeah. Okay. A lot of questions I'm getting online, trending right now have to do with Kanye West. Now, I can't even count how many people are asking me in person, online, hey, doc, or hey, Mike, you're a psychiatrist. What is your diagnosis? What is going on with Kanye West? And, this brings me to an important rule, professional standard, ethics. I don't know what you want to call it, but the Goldwater Rule.
Yeah.
And let me read that for the audience. As far as asking a psychiatrist or mental health professional to make a diagnosis about someone they don't know, the Goldwater Rule is an ethical guideline established by the American Psychiatric Association that prohibits psychiatrists from offering professional opinions about the mental health of a public figure whom they have not personally examined and who have not given them consent to share such an opinion. Now, you see people going on the media all the time, even mental health professionals that are throwing out diagnoses about major figures like Kanye West. And that is not actually per our ethical standard, per the APA.
Yeah.
What do you think about offering your professional opinion about public figures in which the only things that you have to, the only data information you have are the things available to the public rather than any sort of like formal evaluation of the patient, which of course, if you had a formal evaluation, you wouldn't share that anyway because it's confidential. But what do you think about this? Offering your opinion about public figures and their diagnoses?
Well, I mean, the question you're asking makes me think, because the question with Kanye seems like he has a lot of really extreme behaviors that seem like not necessarily socially sanctioned. That's my understanding. I'm not following this too closely, but that's my awareness of it. I would say that I'm pulling on my experience with forensic work here pretty regularly when I'm evaluating defendants. I end up with this question where I'm seeing a person who has some impulsive behavior, and during these impulses they've allegedly broken laws or something like that, or there's been sort of like a negative outcome. And the question that's always on my mind is like, are they doing these impulsive behaviors because they have some sort of a bipolar like diathesis, and it's just they really have no control over this. Like something has gone wrong, and they're overwhelmed by these urges that come up, and they don't have any ability to really stop it. Or are they acting on their impulses because they're more classically like an antisocial sort of personality where they're disregarding the importance of the rules of society. Yeah. They think that the rules don't apply to them or something. Is this their choice? Exactly. That's ultimately the question. And I've met a lot of people doing this sort of forensic work, and I've done a lot of these evaluations. And at the end of the day, really the conclusion that I've come to is that, and maybe this isn't very satisfying, but it's really got to be a person by person thing. And even for any individual person, also it changes from like moment to moment or day to day. Because a person could have like a bipolar disorder. They could be manic, but then the mania may have resolved at some point, and then they might be left with residual antisocial like actions and traits. Like maybe they just have a tendency to disregard, the well-being of others when they're considering what their actions are going to be, or maybe they're actively hostile towards it, and that could be a person with bipolar who also has some antisocial traits. And the question is, were they acting because of a bipolar episode, like a manic episode, or were they acting because of solely the personality? Or even more difficult is, I run into a lot of people who are sort of like partially treated, like they've been given a little bit of a mood stabilizer, and then the mania is sort of coming down, and then there's still these sort of antisocial, traits where they're disregarding the more callous and has lack of empathy and stuff, and then it's a blend, Maybe when you ask this question, I don't think you always think, well, it could just be actually a blend of the two. Like they could be like coming down from a mania, still a little ramped up. And then also they could be like a little antisocial, like, and it could be, this is what's leading to these sorts of behaviors. So for Kanye, I have no idea where he is. Let's say that he does or he doesn't have some disorder that might be contributing to his behavior. I don't know. And then I also definitely don't know enough about the history of his life to know what personality traits he has.
And I think a good psychiatrist has the humility and experience to know that it is very dangerous to speculate on someone and their behavior and their decisions when you do not know this person, have not evaluated this person. So I think one needs to have the humility to not speculate publicly on any sort of, diagnoses of a public figure.
Yeah.
If I'm invited onto this show or that show, I have a lot of hesitation. More than hesitation, I never throw out my opinion about what the diagnosis is of some sort of media figure. It feels a little bit irresponsible, and it feels irresponsible, and it feels a little naive.
Well, there's it's certainly not sophisticated, right?
No.
But then on another level, it lacks a certain respect for the personhood. Like if you think, I've been trying to talk today about like knowing the whole person, all of the experiences that they have in their body and all of the tendencies that they would have grown up with, and then, biological and otherwise, right? And to try to give some sort of a diagnosis from afar, it can be tempting to do because you'll see like the traits, or the sequela, or it will seem so obvious from what the news says. But the reality, if you actually try to do an evaluation and like be honest and write a report, like a forensic report stating these are the things that I see that justify my diagnosis, and this is why I believe they're in a manic episode right now, and this is why I believe they have some personality traits, but those aren't really in fact. Like it's just, there's a lot that could be going on, and to respect them as a whole person would be to like withhold judgment until you finish writing the report,
Yeah.
And you can't do that with a public figure that you're not evaluating. You just can't. You don't know them.
Agreed. Now that just leads me to, at the beginning of our talk, we talked about, we discussed how we don't feel like someone is depressed for no reason. There's always some sort of conscious, unconscious reason.
Yeah.
There's some self-defeating, repetitive pattern. No one is depressed for no reason.
Yeah.
Now, I ask you that same question in patients that have been diagnosed bipolar. So I'm curious about the ISTDP perspective of bipolar. And within bipolar, can a mood episode, whether it's a major depression or a manic episode, be triggered, begin without any sort of trigger, without any sort of underlying reason? So what is your view of this, and what is the ISTDP view of this?
Well, I want to give you my whole opinion. When I think about mania, one of the problems that I have with depression, I can always talk with the patient and then ask questions and then eventually find like an origin. Maybe not like a specific origin, but we can find a constellation of factors that will contribute to, these depressive defenses. But with mania, I have such a hard time getting a clear history because when I'm talking with someone while they're manic, then obviously you're not going to get like a clear history there because there's too much extra stuff happening. And after the mania is over, I rarely have people. Sometimes I do, but I rarely have people who have a lot of clarity of mind and like what was happening during the manic episode. It seems like it's harder for them to recall it. So I don't have a lot of experience really chasing that down. I would say in that respect, specifically for mania, I don't know because I don't have experience.
Mania aside, depressive episodes. Hey, doc.
Yeah.
We've talked about how depression, there's, you live well, you're in touch with your feelings. I want to do my best to like engage in this therapeutic work so that I can prevent any sort of risk of major depression because you told me that major depressions never happen for no reason. So if I live my life in this way and I don't avoid and I confront and I'm in touch and I live this sort of life in, this way, I can reduce chances of having a major depressive episode. But if I'm bipolar, can I just get depressed out of nowhere because I'm bipolar and it doesn't really matter?
Yeah, I would say, so this is I try to take a more complex view whenever I'm talking with someone with depression for two reasons. One is that if I start from the stance that you're depressed right now and that there's no cause other than just some ethereal, the bipolar diagnosis maybe do it, then there's not much that I can do from a from a psychotherapeutic standpoint. We can always use the antidepressants, and that's always an option, and I do that, and they're effective, and that's great. But if a person wants to try to understand the machinations of their mind, if they want to get in touch with their psyche, then I start from the stance that no matter what, we can find out what happened. If you don't believe that you can figure out what's going on, then you'll never figure it out.
Yeah.
So I always start from that stance anyway. And then then the next step is to be curious, and to not jump to becauses too quickly. If you jump to, well, this happened and because of that, that's why I did this. Well, you say because, you're closing the door, Well, you say because, you're telling me you already know why it happened, right? But if you keep your mind open and say, well, maybe that's a factor, maybe this is a factor, you can see what might be contributing. I want to say that for anything that has like a genetic component, because we have some control, not ultimate control, but we do have some control over our minds and over our bodies. I want to say that even if there is a genetic predisposition or a biological predisposition, or just a social predisposition, it could be a cultural predisposition. Maybe you have a culture that really favors the depressive state, for example. I don't know, right? But whatever it is that gives you a predisposition for it, if you ask the question, when did the depression start? And then go to that moment and then try to figure out what's happening there, I want to believe that we can find something that you can work with.
I agree.
Something that you can understand.
I agree 100%. So now we're going to ask Dr. Kanell for some audience questions from our social media. First, why don't psychiatrists engage in self-disclosure? Meaning, why don't psychiatrists ever talk about themselves to the patient?
I have a lot of thoughts about this. When I was in training, we had a couple of supervisors who were really much more open about it. And they're like, no, self-disclosure, it can really strengthen the bond. And I thought that at the time, but as I've worked through and I've done, especially doing more therapy with patients, I really think it's incredibly beneficial for the patient to not know much about you, because we come in with so many preconceived notions about what an authority figure is like. And a lot of psychotherapies is trying to take down this authority figure relationship that the patient oftentimes comes in with. When you're doing therapy, if you come in as a patient and you're looking for this person to be the know-it-all, the one who's going to save you, the one who's going to reach into your past and make everything clear, then you're going to fail, because the real goal of good psychotherapy is to help strengthen you. It's so that you can become the leader in your own life. Like if you had a lump
empower the patient.
Exactly. It's to empower the patient to dream and to desire and to be curious and to go out and live a life, because we only get this one life. We're here now, And that's the goal of psychotherapy. And insofar as you're looking for this other person to save you, then the therapist becomes a crutch. And that will cripple the patient from being able to make the changes they need to change. Because to really get in touch with the authentic feelings, if you're looking to someone else to do it, you're going to always be asking the other person to pull this feeling out of you or to make it happen. So it's super important that the patient not know anything about me, because the more they know about me, then the more they're going to be able to imagine, like, I'm some person who maybe knows a lot and will have like judgments. Maybe they'll be less likely to tell me about a part of their life because like, Dr. Kanell's not going to be accepting of this or accepting of that. I can't tell him that I'm mad at him about this thing because he, has some issue with, religion or something like that.
Absolutely.
So you want to be a blank canvas.
Yeah. Also, when you're working with transference and countertransference, transference specifically, the feelings that you're feeling directed towards you from the patient when they don't know anything about you are valuable. If you start giving personal information about yourself, you're starting to compromise and introduce information that will, again, compromise the transference from the patient. Again, let's say he knows I'm single or I'm married. Maybe I'm married and now he's insecure about being single. He's going to now think that perhaps feel like there's going to be some sort of judgment because he wants to live a single lifestyle. So I never self-disclose. The majority of the self-disclosure that I do with my patients is really pointed if I feel like I can very much relate to a patient and I want to improve the therapeutic alliance and the bond and recognize that they know I can truly empathize with them. If 0 to 100, I am at like a 2 as far as like how much I self-disclose about myself. My patients will learn more about me by watching this podcast and the little bits that we have here and there than they will ever learn about me in our sessions.
I think there's another aspect about self-disclosure that's important, and it's that when a patient comes to you for psychotherapy or for treatment, they're looking to help their life get better. And ultimately, your life as the therapist, your opinions as the therapist, your beliefs as the therapist, your history, none of these things should matter because that's about you. You
Absolutely.
know? We're here to deal with the patient's life and the patient's whole authentic self, you know?
Absolutely.
And any piece of myself that I bring in, you know, could budge that out. I want the therapy room to be a place of consideration and curiosity and freedom of thought and freedom of feeling.
Absolutely.
I don't want to block that at all.
Agreed. We're running out of time, so we're going to cut it short with the audience questions. Dr. Kanell, if you could give the audience just one piece of advice for their mental health and wellness, what advice would you give them?
So the advice would be to be curious, but when I give this, I know that it's hard. So, you know, you don't just take this as like, oh, you should just be curious and then that will solve all your problems. But I think that if you can, when you get a feeling or if you have like a mental health experience that's tough, you know, rather than think that it's because of one thing, you know, to assume that it's this one thing, if you can be curious about what other causes might be there, and then if you can start asking yourself curious questions like, well, when did it start? You know, is there anything that made it worse? Is there anything that made it better? These are classic medical questions, you know. But if you can ask yourself these questions about your mental health symptom, and then you give yourself some honest answers, and you keep exploring, I think you will be able to paint a much more full picture of what's going on in your life.
And to add to that, I think it helps to journal. I think it helps to write things out. It activates a different part of your brain, whether you're thinking or actually writing. And there's a famous saying, it's harder to believe the lies you tell yourself when they're written out right in front of you.
Yeah, that's a smart idea because the thoughts that you have can come so quickly, and it can be so easy to have like even directly opposing thoughts very close together and to not feel like they're contradictory.
Yeah.
But if you write it out, then you can see it.
Not to mention, a lot of people avoid a thought. There are thoughts that are so potentially disturbing or distressing or disruptive to one's life, or if actually thought out to their conclusion, the behavior associated with damage somebody else or hurt somebody else. There's a lot of actual thought avoidance. So when you sit down and you actually start journaling and writing a thought through, a fear, a worry, a feeling, any sort of thought all the way through, there's power in that as well, because it's much easier to notice when you've gone halfway through a sentence and stopped than when you're avoiding a thought.
Because there's no groundedness. It's not firm. And what that reminds me, something that I've thought about, as you're looking at all these different therapeutic modalities, whether you're thinking about classic psychoanalysis or ISTDP or CBT, or even newer therapies like ACT, you know, one thing that's common to a lot of them is that just having a thought or even just having a feeling, you know, these internal experiences that we have, they're not the same as actually acting on them or doing an external thing. We will always have thoughts that come up that are bothersome or feelings that come up that, you know, are not necessarily that if you were to act on them would lead to problems. But just having the feeling and experiencing it is not the same as acting on it. You know,
Bingo.
Having the aggressive feeling, having the sexual feeling. These are not things
that is so important.
But acting on it is there's a huge difference between having it and letting yourself have it and then moving on with your life versus stewing over it and blocking it, you know.
Absolutely.
And then eventually it leaking out in some other way, you know.
100%.
Just having it is not acting on it. And it's important to be aware of that.
Yeah. Now, ISTDP therapy, not every patient is appropriate for ISTDP therapy. When you first start, you undergo what's called a trial therapy, and they assess for the fragility of one's ego. Now, I know I'm going to keep you about 5 minutes over. I'm sorry about that.
Yeah.
Can you just tell us what you look for in your trial therapy? Who's an appropriate candidate for ISTDP? What is fragility of ego? And landing at what sort of patients should come to you, and then tell the audience how to get in touch with you and book an appointment.
Sure. So the most important thing that I look for in a trial therapy is if the patient wants to do this kind of work. You know, there's something, because you come in having a complaint, whether it's, you know, anxiety or depression or a relationship issue or like motivation problems in your life, you know, phase of life issues. You'll come in with some sort of a specific symptom that's going wrong in your life right now. But during the questioning and during the therapy, we'll want to try to like see, are you open to trying to explore your total experience? You know, are you curious about it? Do you want to try to take a look at it? Do you recognize that there's a piece of something that's going on inside of you as you live your life that you're cutting off, that you're blocking out, that maybe you're not doing it on purpose, but maybe it's just shut off from you for some reason? You know, can you acknowledge that that's there? And then are you interested in trying to get to know that part of you? You know, are you interested in trying to figure out, well, what is it that's happening? You know, why am I doing this? You know, I'm so confused as to why, like why do I keep pulling out of, you know, all these offers that I have for good jobs or something like that? You know, this is if you're willing to be curious about that and you want to figure it out, then that's the most important thing.
Yeah.
You know, do you want to do deep introspective, potentially very painful work?
Absolutely.
You know? And if you're on board with that, then I think we can work through the rest of it. Like I said earlier, classically you check for fragility. That's if when you press for feelings, does the person get all the way up to the highest levels? And so to go up to like a cognitive, like a scattered thoughts and confused and depersonalized or disassociated state, that can be problematic, and it can make it hard to do the therapy. But if it just happens like periodically or once, that doesn't mean that you can't do the therapy.
Yeah.
Right. What it means is that we need to go slower. We need to be paying really careful attention to your anxiety. Right. But if it happens immediately and it happens persistently, and if there's no way to really regulate it, like if you're not really responding well to the interventions, then you probably need a more gentle form of therapy that might not go as quickly as ISTDP, but you will want it. But that's what you're going to be more receptive to, and that's where you're really going to see change happen in your life. Mm-hmm. So that's another thing that I do assess for.
Yeah. And quickly, because ISTDP by definition, they have like a time limited approach, meaning they want results quickly. Quickly meaning being, I think, between 6 and 18 months. I mean, you'll tell me. Yeah. But that sort of, we want to get you better quickly is part of the ISTDP principle, isn't it?
Yeah. Yeah, they're actually in the most recent. There's an ISTDP journal. Someone actually wrote an article. I saw the title. I just got the journal the other day. I haven't read it yet, but the title was that they were proposing like maybe you just start off with a specific number of sessions, that you're going to do, and they talked about the pros and cons of that. And there are pros and there are cons. One of the cons is ideally if you're making progress in therapy, you'll know when you're done. But then the other thing is if you have a fixed number of sessions, then that increases the pressure. And I don't know if we've said this explicitly, but
fascinating.
ISTDP is about increasing the internal pressure to do something. Because it's about recognizing that on some level you're in an emotional crisis and that your life is on the line. like the value, like every day is a day, you know, you only
Yeah.
get so many days, right? ISTDP knows that there's an urgency to that, and it wants to help you to make changes as soon as possible. It's not as rigid as the CBTs where you get like 16 sessions or 18 sessions. But it should be shorter term than, for example, psychoanalysis. Classic psychoanalysis can take years, you know, famously.
Absolutely.
Some famous people have been in for decades, you know. So you want to be much quicker than that, because we don't want to be doing therapy for our life. We want to do therapy and then live our life.
Absolutely.
Yeah.
Dr. Michael Kanell, double board certified general adult psychiatry, forensic psychiatry, an expert in intensive short-term dynamic psychotherapy, ISTDP. So if someone wants to book a visit with you, how do they do that? And where are you located?
Well, so I'm working over Zoom right now, and I can see anybody in California or Tennessee.
Tennessee as well, you're licensed?
Yeah, I'm licensed in Tennessee. I can see them over a video conference, and they can find me on my website. It's www.eospsychiatry.com. That's
EOS Psychiatry, and we'll link it down below.
Yeah.
Dr. Michael Kanell, EOSpsychiatry.com, ISTDP.
Yep.
Thank you so much for joining us.
Thank you so much for having me. This is great.
Thank you.